Now on to metastatic breast cancer. Rohit, you had mentioned just in the last few months, we've seen quite a bit here. Kevin, can you walk us through our available treatment options? And importantly, how are you sequencing all this today in your clinic?
Yes. So as if the early stage setting wasn't active enough, you can see there's a lot going on in the metastatic setting. One thing that I have seen come up with my community oncology colleagues, in fact, yesterday I fielded two questions about this from two different community oncologists. The Inavolisib approval. So that is a new PI3K inhibitor. It is only approved right now in combination with palbo and fulvestrant. Okay, is approved as triplet therapy. We do not have is not approved with ribo. It is not approved outside of this setting right now. We'll see other studies in the future answering different questions with Inavolisib. Inavolisib is only against PI3K inhibitor. These are for patients who have PIK3CA mutations. In this approval of the triplet is for a very specific population. This is for newly metastatic disease for patients who have tumors that progressed either on their endocrine therapy in the adjuvant setting or within 12 months of completing their adjuvant endocrine therapy. So those endocrine resistant patients. And we've seen
Oh,
from
that's,
the
that's,
press release that there is an overall survival benefit,
that's
which
great.
is meaningful. We have yet to see a survival benefit with any PI3K or AKT or mTOR inhibitor. This is the first time we're seeing an overall survival benefit because the question has come up, triplet, that seems hard, that seems costly. We see an overall survival benefit now, but of course we'll see the data later on this year.
Kevin, there's quite a bit to discuss here. Before we move on to the topic of Inavo and other agents, there has been exciting debate about T-DXd. What we have seen is based off of DB06 approval of T-DXd in low and ultra low settings. Outside of clinical trials, would you use this in a patient with no HER2 expression at all? Especially when this test is so subjective to begin with, and now out, especially in community, asking pathologists to commit to no HER2 expression or ultra low HER2 will take some time.
Your question is like the heart of the matter. Like, how are we measuring HER2? Is it really that precise? It's an active drug. Like, should everybody get this drug? Right now, I'm at a center where the pathologists are quite engaged and they'll say
Right.
on their report, they don't say HER2 low or ultra low. They'll just say, zero, but with some membranous staining. Then
Right.
that's the way of saying that it's, ultra low.
Right.
I will say I've been using this for ER positive disease, for anybody who's ultra low, or HER2 positive. I haven't used it for HER2 zero, though we also know that the more biopsies that you do, you may find something at some point that's going to show either a
Right.
low finding. The one caveat to that is if I have a patient with triple negative disease and that HER2 is zero and I'm running out of options, I have tried to get it in that setting.
What was the response rate there in your clinical anecdotal experience?
Low.
Mm.
Okay, so coming back to hormone receptor positive, Inavolisib for this high risk group, and then of course what we have been using CDK4/6 inhibitors with endocrine therapy if they don't fall into the Inavo group, and then thereafter looking for these actionable mutations, ESR1, PIK3 if you've not used it, AKT, PTEN, of course also the germline BRCA mutation. So looking out for these NGS actionable mutations, very important. What next? T-DXd, likely anyone who fits into that bucket, keeping your ILD, nausea, alopecia in mind. Then, Kevin, this gets even more complicated. We have chemotherapy, sacituzumab, Dato-DXd recently got approved. Should there be a little break from ADC to ADC? Kevin, how are you sequencing these options in endocrine resistant disease?
Right. Few thoughts in like no order of importance. All right. First of all, we do have data that for those patients who have germline BRCA mutations, they may not respond to endocrine therapy and CDK4/6 inhibitors for quite the same duration. So it's just one thing to be mindful of. Also, I find capivasertib to be much easier to tolerate than alpelisib. So I think that, we really started to favor that. And of course, the dosing is, 4 days on, 3 days off, and it's given twice a day when it's on. The other thing just to know as like a clinical pearl, is that if you're checking circulating tumor DNA, it may be harder to find PTEN alterations. And so it is one thing to think about if you have a patient who doesn't have a PIK3CA mutation or AKT1 mutation. You may want to look in the tumor also, just to make sure that it's not a patient that may benefit. All right. So let's say a patient doesn't have endocrine sensitive tumor anymore. For those patients who have a low volume of disease or low cadence of progression, capecitabine, still our friend, still appropriate for us to think about. Outside of that, I do agree. T-DXd is a very good option. We've seen this compared to standard chemotherapy. The problem is, and you've already kind of alluded to this, is that second ADC is never as good as the first ADC for the most part. Like there's some data in these series that maybe, but we really don't know who those patients are. So the first one's generally better, and the payloads are the same mechanism of action. And so I do think it's reasonable to do after T-DXd, either Dato-DXd or SASE, like either are options. We don't see that giving any chemo in between is any better than going directly one after the other, though those are just institutional data. And then the other question that has already come up from community oncologists is, would you do like a T-DXd to a SASE to a Dato? I don't think so. In the original phase 1, there was a small group of patients who had prior SASE that responded to Dato, but most did not. And to me, I would think more about what TROP2 am I going to think about utilizing. For those that haven't had experience with Dato, I just want to mention, just got approved, it's given once every 3 weeks as opposed to 2 weeks on, 1 week off with the SASE. With SASE, everybody loses your hair. Dato, not everybody. The rates of ILD are still low with Dato, but with Dato, stomatitis, right? It is important that you are using the Dex rinse, or if you have access to it, preventatively. They recommend that you eat ice chips as you are having an infusion. You're really not supposed to be wearing contacts during the infusion or actually during the time that you're on Dato, though the rates of ocular issues are low, and it tends to be more just keratitis, just more inflammation. So that's how I'm contextualizing the ADCs right now.
Thanks, Saraj, for covering that. And at least for here in hormone receptor positive, T-DXd first, and then sacituzumab or Dato-DXd. In triple negative is slightly opposite, especially how we've seen the results or the responsiveness.